Assalamu alaikum everyone. I hope I find you all in the best of health. I'm Ayesha Zulfikar and I warmly welcome all of you on behalf of Giving Back to Pharmacy in Pakistan. So today the topic of our class is men's and women's health, which will be presented who has done her Pharm.D from Karachi University and passed her BCPS exam. She has worked as QC analyst at Pfizer Laboratories and now she is working as a pharmacist at Sheikh Khalifa Medical City in Abu Dhabi. So ma'am, thank you so much for giving us your precious time. It's over to you.
अस्सलाम वालेकुम। अब आप लोग सुन सकते हैं मुझे? हेलो।
यस मैम।
हाँ, ओके, सॉरी, मैं कंफर्म कर रही थी कि मेरी आवाज आ रही है या नहीं आ रही है। ठीक है, थैंक यू फॉर इंट्रोडक्शन आयशा, and we share the names. So I'm starting with men and women health, and previously it is the same lecture as we did previously in 2 years, so I will just continue. So topic here I'm covering are menopause and hormonal therapy, and we will give some overview of osteoporosis and some drugs used in lactation and pregnancy, some complications related to pregnancy, overview of contraception and emergency contraceptive medicines, some infertility medicine, and some sexually transmitted diseases. So start करते हैं presentation. ये disclaimer है कि I have not received any financial or commercial funding for this program. So first topic is menopause and hormonal therapy. So menopause can be defined as cessation of menstrual period for 1 year or loss of ovarian follicular function. And the symptoms which comprises of menopause are mainly two: vasomotor symptoms and GSM. So vasomotor symptoms are commonly known as hot flushes, and these are the main reasons to start any hormonal therapy for treating menopause, because they can badly affect for quality of life by sudden increasing skin temperature and causing palpitation, diaphoresis, night sweats, can lead to fatigue and affect daily activities of life. So, and second symptoms for menopause is genitourinary syndrome of menopause, and it encompasses both vaginal and urinary symptoms, and it includes, as it is syndrome, it includes vulvovaginal atrophy, which can cause pruritus and pain. Okay, I have messaged that my voice is not clear. Not clear means it's a problem with my voice is low, or my voice is not clear because of internet problem. Echoing. What can I do for echoing? Okay, I will start now again. Then let's see if they can understand me or no. It's okay. Is it okay? I can start? Okay, fine. So we were discussing about symptoms of menopause. These are vasomotor symptoms and GSM. So I was discussing GSM. GSM is syndrome of genitourinary syndrome of menopause, and it includes both vaginal and urinary symptoms and include vulvovaginal atrophy, leads to pruritus and pain, and dyspareunia, and because of some pH changes, there are chances of bacterial colonization, which can lead to UTIs, and thinning of urethra and bladder lining, which may result in recurrent episodes of urinary frequency, urgency, and dysuria. So the main hormones which are participating in normal female cycles are estrogen and progesterone, and during menopause their concentration become less. All the systemic effects in the menopause are because of estrogen and progesterone declining levels. So these are the some benefits and risks which you to memorize, and these benefits are and risks actually will help you to choose any product in coming slides, in coming discussions. Uh, with I forgot. Okay, these benefits and risks only you to memorize and have a little idea how estrogen is beneficial to treat menopausal symptoms, and progesterone is beneficial to treat some of the menopausal symptoms and their risk associated with it. So estrogen when taken exogenously, benefits are it relief from genitourinary atrophy, it gives relief from mesomotor symptoms, and it help in reduction in osteoporosis related to menopause. It help improvement in insomnia and fatigue caused by decreasing hot flashes, stabilize mood swings, decrease pain with sexual intercourse. And risk associated with estrogen when taken exogenously are endometrial cancers, breast cancers, gallbladder effects, VTE risk, stroke risk actually double with estrogen therapy, and some cardiovascular health, coronary heart diseases. Okay. Then progesterone is beneficial in terms of decreased risk of estrogen-induced irregular bleeding and endometrial hyperplasia and carcinoma. And adverse effects of progesterone are bloating, weight gain, irritability, depression, which are all dose related. Treatment or management of menopause. So, treatment or management is mainly by hormonal therapy, including estrogen and progesterone combined therapy, estrogen only therapy, and SERMs. SERMs are estrogen receptor modulator, which actually acts as agonist when there is less concentration of estrogen, and they act as antagonist when there is high concentration of estrogen is present. So their effect is different in different tissue according to the estrogen level in particular tissue. There are some FDA approved indication where hormonal therapy is recommended. So only for the treatment of moderate to severe vasomotor symptoms, hormonal therapy is recommended. In some moderate to severe vulvovaginal atrophy because of menopause, and in this case recommended is local hormonal therapy. We try to avoid taking any systemic hormonal therapy in order to reduce the systemic side effects. Prevention of postmenopausal osteoporosis, and fourth one is premature ovarian failure. Next slide. So formulation available for hormonal therapy are oral, transdermal, and vaginal. And according to the condition, we choose which formulation is best. For oral formulation, they are mostly used for treating vasomotor symptoms, and they cover some GSM if present concomitantly. Transdermal patches are usually recommended for people who are intolerant of taking oral preparation, and they are the first line formulations for the women with moderate risk of cardiovascular disease if estrogen is needed for them. And they cover vasomotor symptoms and GSM both. Vaginal and local preparations are usually for treating genitourinary syndrome of menopause, and usually it is recommended to take local preparation before trying to oral preparation for GSM in order to relieve symptoms. If vasomotor symptoms are present, we can use oral and transdermal. If GSM only, we can choose vaginal and local preparation. Risk assessment. Okay, before initiating any hormonal therapy, these are the points to consider for risk assessment. Okay, if woman is high risk of VPE and she is requesting hormonal therapy for controlling her symptoms, we will prefer a non-oral route of hormonal therapy at lowest effective dose if it is not contraindicated. If woman is at high risk and she has a history of breast cancer, we cannot choose any hormonal therapy. We will go for non-hormonal treatment for symptomatic relief for menopausal symptoms. For women with high risk of cardiovascular diseases such as myocardial infarction, peripheral artery disease, or any chronic kidney disease, and their 10 years CVD risk is greater than 10%, again non-hormonal treatment is recommended for symptom relief. And for women with moderate risk of cardiovascular disease, transdermal estradiol with appropriate use of progesterone is recommended if hormonal therapy is needed. Treatment and management. So these are the groups and then agents, and we will discuss some important points for the agents. Hormonal therapy, estrogen, available products are ethinyl, estradiol, metronol, DES, tibolons, dinesterol. They are used in moderate to severe cases of menopausal symptoms. And estrogen can be taken daily without any interruption in the woman who has hysterectomy status. If patient with menopausal complaint has intact uterus, we cannot give estrogen alone because in previous slide we learned that estrogen can cause hyperplasia or endometrial cancers. So in order to decrease the risk of decrease the side effect of estrogen, we will add progesterone in such cases. So patient with hysterectomy status, we can give estrogen daily without interruption. Transdermal estradiol patches are recommended for women who are intolerant for oral preparation or are non-compliant for daily administration. Then local preparation, again we discussed earlier that for these are first line agent for controlling symptoms of GSM. Second agent, estrogen plus progesterone, estradiol, northindrone. So these are combined estrogen and progesterone, and this is keep for the women with uterus which needed hormonal therapy, but to decrease the side effect of estrogen, progesterone is added as cyclic progesterone for equivalent of 10 to 14 days per month, similar to female cycle with a withdrawal bleed each cycle. Selective estrogen receptor modulator, example is aspirin, and it is indicated for treatment of moderate to severe dyspareunia caused by vulvar vaginal atrophy of menopause. Contraindication of this product is severe hepatic impairment. Another SARM is conjugated estrogen plus bezidoxifene. So mainly conjugated estrogen is used for treatment of osteoporosis after menopause. But this conjugated estrogen plus bezidoxifene also used to treat moderate to severe vasomotor symptoms. Then we have another option, serotonin reuptake inhibitor. Examples are paroxetine, sertraline, venlafaxine. These are agents which used in the patient who are at high risk and where hormonal therapy is not recommended, and they need some treatment for vasomotor symptoms. So SSRI is the best choice for non-hormonal control of vasomotor symptoms. Other products are DIA, androgen, phytoestrogen, megestrol. Natural products, black cohosh, they are used for vasomotor symptoms, and it also can help in osteoporosis management. Other products are clonidine, gabapentin, pregabalin, but they are not FDA indicated for controlling the symptoms, but off-label they are being used. Okay, this is the case for for example, if JK is 15-year-old postmenopausal woman with severe hot flashes that have not resolved with venlafaxine 75 mg orally daily. She is otherwise healthy with no history of cancer and no surgical procedure. She is given conjugated estrogen 0.6 to 5 mg orally daily. Which treatment is best for JK? So here we will consider that patient has hot flushes. She is using venlafaxine to control symptoms, non-hormonal therapy, but it's not effective now. She has no history of cancer, so she can take estrogen. Okay, but she has no surgical procedure, means she has intact uterus. Now they add estrogen in his regime, in her regime. So what other treatment is best for GK? Options are no other drug is needed. Estrogen alone is sufficient for hot flushes. No, actually she has no surgical procedure. So medroxyprogesterone or any kind of progesterone should be added to oppose the hyperplasia syndrome, endometrial hyperplasia risk of estrogen associated with estrogen. So option A is wrong. So no other drug is needed. Estrogen should be discontinued and she should continue on venlafaxine. So option B is wrong because she is already taking venlafaxine and complaining of still hot flushes. So B is again wrong. Medroxyprogesterone acetate should be added to decrease risk of stroke. C is correct in the sense it should be added, but in not to decrease the risk of stroke. There is no correlation of medroxyprogesterone to decrease the risk of stroke. Medroxyprogesterone acetate should be added to decrease the risk of endometrial cancer. So here the option D is the best for this case. In this way, we are solving the cases. Overview of osteoporosis. Next topic. So osteoporosis is where we have porous bone or weakened bone, which can lead to unexpected or sudden fractures. And this condition is usually asymptomatic without any pain, and it cannot be discovered until you have sudden fracture. So for the overview, bone are growing tissues and they have two parts, inner spongy part called trabecular bone and which is covered by hard shell called cortical bone. what happened in osteoporosis? The inner spongy part, the bone porous, the spongy bone become more porous, and numerous large numbers of pores are inside the spongy part, and then it becomes less uh, less dense and less bone mass and less strength can be a cause of sudden fractures. Bone also stores calcium and mineral, and when body is in need of calcium, it breaks down, release calcium, and rebuild itself. It's called bone remodeling. But after the age of 35, this breakdown become more faster than the bone buildup, which actually cause gradual loss of bone mass. So how we diagnose it? Diagnosis according to WHO is based on T-score, and T-score is obtained by getting DEXA, and it can be defined as the measure of standard deviation, statistical measure that reflect the difference between your bone density and the average bone density for healthy young adult of your sex. So according to WHO, there are two terminologies. One is osteoporosis on the basis of T-score, and then other is osteopenia. If the T-score is less than, if the T-score is of minus 2.5 or less, the term is osteoporosis. If T-score is between minus 1 and minus 2.5, the condition is called osteopenia. The cornerstone of osteoporosis therapy is bisphosphonate. Just memorize this. So osteoporosis major cause is decreased level of estrogen in postmenopausal women, because one of the systemic effect of estrogen is strengthening bone. So risk factors are 50 years of postmenopausal women, early menopause before the age of 45, or prolonged menopause, amenorrhea, white Asian race, thin build, hyperthyroidism, or not having natural born child. Some drugs which can cause osteoporosis are anti-epileptic drugs, for example, phenytoin, steroids, heparin, excessive levothyroxine, GnRH agonist, lithium, chemodrugs for breast cancer, and some factors are family history of osteoporosis, low calcium and vitamin D intake, sedentary lifestyle, decreased mobility, cigarette smoking, alcoholism, history of falls. Recommended BMD testing. So previously we discussed that osteoporosis is the condition which is asymptomatic. There is no pain. So how we will diagnose it in order to prevent severe fractures or severe consequences of osteoporosis. So recommended is the BMD testing for all the women who are 65 years or older, or all the men who are older than 70. And then men who are in the window of 50 to 69 years of age with previous fractures or risk factors such as delayed puberty, hypogonadism, hyperparathyroidism. So they are using drugs such as glucocorticoids, GnRH agonists, and other secondary causes of osteoporosis. And then all postmenopausal women with medical cause of bone loss also recommended for BMD testing. Then postmenopausal women who are younger than 65 years, but they have at least one of the following together. It's like previous fracture after menopause, other than skull, facial bone, ankle, finger or toe. Thickness, body weight is less than 127 pounds, or BMI less than 21 kg per meter square, or history of hip fracture in a parent, or starting or taking long-term systemic glucocorticoids for 3 months or longer. length of therapy or initiation of therapy. Okay, so we know now T-score, we know now BMD testing. So when it is needed to start treatment to prevent osteoporosis. So first point is if there is a hip or spine fracture. Second is if BMD T-score is minus 2.5 or below at the spine, hip or femoral neck. And if BMD T-score is between minus 1 and minus 2.5 at the femoral neck or spine, and the 10-year probability of hip fracture is 3% or greater, or the 10-year probability of major osteoporosis-related fracture is 20% or greater. In these conditions, we will start treatment, initiation of drug therapy. Length of therapy is usually 5 years, and during that, follow-up is required for between 2 years, but it's not recommended if patient is on 5 years of osteoporosis therapy. The BMD testing is not recommended every 2 years. Treatment options. First option is the cornerstone of therapy is bisphosphonate. Members are alendronate, residronate, abendronate, zoledronic acid, atidronate. Risk of adverse GI effects, and there is interaction of drug-food interaction. So better to wait at least 30 minutes after taking medicine for the food. And bisphosphonate should be avoided if creatinine clearance is less than 30 mils per minute. And major side effects of bisphosphonate is osteonecrosis of jaw. Calcium and vitamin D are supportive treatment with bisphosphonate, and recommended dose of calcium for women less than 50 years of age is 1000 milligram, and greater than 50 years of age 1200 milligram. For men 50 to 70 years 1000 milligram, greater than 70 years 1200 milligram. Same for the vitamin D. It's recommended for all the patients with osteoporosis, and it actually helps or promotes calcium reabsorption. Recommended dose is for 70 years old, 800 units per day. If less than 70 years old or younger, the dose is 600 units per day. Other agent is SERM, selective estrogen receptor modulator. Example here for osteoporosis treatment is raloxifene, and it is used for prevention and treatment of osteoporosis in postmenopausal women and treatment of vertebral fractures. Contraindication is pregnancy or nursing and having VTE history, because it's here this term is acting as estrogen agonist. Okay, so VTE history, pregnancy and nursing. Then next example of term is conjugated estrogen and bazidoxifene. It's also used for prevention and treatment of osteoporosis in postmenopausal women. Contraindication is again pregnancy, VTE history, and hepatic impairment. Calcitonin salmon. It is not the first line treatment to be used for the osteoporosis, and it's actually reserved for the postmenopausal women with osteoporosis and postmenopausal women greater than 5 years. And it has it is associated with risk of malignancy. So while we are considering this as a treatment, every benefit and risk should be discussed with patient. Then other option is teriparatide, human parathyroid hormone. It regulates bone metabolism, intestinal calcium absorption, and renal tubular calcium and phosphate reabsorption. It's also indicated for the treatment of postmenopausal women with osteoporosis that have high risk of fracture, and it helps to increase bone mass in men with primary or hypogonadal osteoporosis and at high risk of fracture. Contraindication for this teriparatide are hypercalcemia because it is also helping in absorption of calcium from the renal tubular uh, from the tubular renal sorry from the kidney, and then bone metastasis and disorders that predispose women for tumors such as Paget's disease. It is also carcinogen, and some studies shows that it can cause osteosarcoma in rats. So recommendation is should not be used longer than 2 years. Then another agent is denosumab, and it is used for postmenopausal women with osteoporosis and for men and women with bone loss, which is associated with prostate and breast cancer. Safety issues are possible opportunistic infections and hypoglycemia. So, vitamin D and calcium supplements are must while using denosumab. Abaloparatide is uh, another parathyroid hormone analog, and regulate bone metabolism, intestinal calcium absorption, and renal tubular calcium and phosphate reabsorption. Indication is for the postmenopausal women with osteoporosis and they have high risk of fracture that is greater than 3%. And it is reserved for the treatment with very low BMD. T score is lower than -3 and have previous vertebral fracture history. So this is summary for treatment of vertebral and non-vertebral fracture. We have option for bisphosphonate, estrogen, bazidoxifene, teriparatide, and abaloparatide. Then denosumab. For treatment of vertebral fracture only, we have option raloxifene and calcitonin. This is patient case. RK is 71-year-old white woman, height 63 inches, weight 64 kg, with history of rheumatoid arthritis, who smokes half pack per day. She is lactose intolerant and has minimal intake of dairy products. She takes calcium 1200 mg orally per day in divided doses and vitamin D 600 unit per day orally. Calculated creatinine clearance is 60-70 ml per minute. BMD score is -2.6 at hip and -2.1 at spine. Praxis score indicates she has 10-year probability of major osteoporotic fracture of 22% and 10-year probability of hip fracture of 11%. Which statement best describes to current diagnosis of RK? Options are she has normal BMD of the spine. The spine BMD is showing -2.5 T score, 2.1, -2.1. So she doesn't have normal BMD. Wrong. Option A is wrong. She has low bone mass osteopenia of the hip. So T score is -2.6 at the hip. Again, osteopenia T score is -1 to -2.5, right? So this option is also wrong. She has osteoporosis of the hip. This is correct. T score at the hip is -2.6. And she has severe osteoporosis of the spine. At the spine, she has osteopenia, not osteoporosis. So in this question, C is correct answer. Which is the best therapy for RK? No further treatment is needed. Continue calcium 1200, vitamin D 600, per day orally. Give abaloparatide 80 micrograms subcu daily. Continue calcium, vitamin D orally daily. Doses are mentioned. Give romosozumab subcu every month. Continue calcium 1200. Increase vitamin D 800 daily. And give residronate orally weekly. Continue calcium 1200 and increase vitamin D 800. Here, okay, consider question. Patient is 71-year-old and his creatinine clearance is normal, 60 to 70. It needs treatment because of the T-scores and the Frex 10-year probability fracture is greater than 22% and 10-year probability of hip fracture is again 11%, more than 3%. So it actually needs treatment. So option A is incorrect because they said no further treatment is needed. Plus calcium and vitamin D doses are wrong. Calcium dose is correct for 71-year-old, but vitamin D should be 800. Option B is showing abaloparatide and continue calcium, vitamin D. Vitamin D dose is low here, 600. It should be 800. And abaloparatide, we are not keeping it for first-line treatment. First-line treatment is always bisphosphonate, and bisphosphonate is suitable here because creatinine clearance is fine. So option B is wrong. Give romosozumab subcu every month, calcium 1200, increase vitamin D to 800. Again, romosozumab is not our first-line treatment. It's not bisphosphonate. So we will not choose. This is not the best answer. D is give residronate and continue calcium 1200 and increase vitamin D to 800. But as of now, this is the best answer. Residronate is one of the bisphosphonate. We will start with it and continue calcium 1200 and increase vitamin D to 800. Next topic is drug use in lactation and pregnancy. So we know that teratogens are the drugs or medicine which have potential to cause abnormal fetal growth or development. So there are many factors which influence teratogenicity, like genotype of mother, embryonic stage at exposure, medication use, simultaneous medication use, time of exposure, and there are some factors of placental transport like molecular weight of drug binding protein, degree of drug binding protein, and then maternal and fetal blood flow, metabolic activities. So before initiating any medication during lactation or during pregnancy, we should do risk-benefit ratio. We should consider drug is really necessary. We should consider most effective agent with least possible risk, lowest effective dose with shortest possible duration, and health of the mother if we are using health of the mother, consider it without drug. So some non-teratogens, these are some examples. And some examples for drug use in pregnancy, if benefit outweighs risk, acetaminophen for antibiotic, erythromycin, cephalosporin, pyridoxine, doxylamine, drug of choice for nausea and vomiting. Some drugs with non-pregnancy risk but should be used with cautions are aminoglycoside, aspirin, benzodiazepine, NSAIDs, oral hypoglycemic agents, beta blockers. Then types of adverse effect after fetal drug exposure can be cancer, can be developmental delay or deficiency, fetal death, growth retardation, low birth weight of for gestational age, renal dysfunction, seizures, sexual and reproductive dysfunction. and thyroid dysfunctional withdrawal. And then drugs which can decrease milk supply, bromocriptine, levodopa, nicotine, pyridoxine. Drugs can increase milk production. They are galactagogues, may or may not be safe in breastfeeding. Antipsychotics, cimetidine, methyl-dopa, metoclopramide, fencerfine. Some drugs contraindicated in breastfeeding according to the American Academy of Pediatrics. These are amphetamine, antimeplastic, benzodiazepine, cocaine, drug of abuse, ergotamine, lithium. Relatively safe are analgesic ibuprofen, acetaminophen, antibiotic penicillin, cephalosporin, erythromycin, caffeine in moderation. This one is the case, and this is actually the exam case. One of the paper has this case. This pregnant woman has history of spinal bifida in previous pregnancy and looking for new pregnancy. What is the best prophylactic regime of folic acid? There are two options. We have folic acid 400 microgram, then folic acid 4,000 microgram 1 month before pregnancy and through first trimester, then 400 microgram through second and third trimester. So this is the recommendation for women who have history of spinal bifida and in previous pregnancies, that we should start folic acid 4,000 microgram 1 month before conception, and then continue it for the first trimester, and then can reduce to 400 for the second and third trimester. So option B is correct here. Then complications in pregnancy. Morning sickness, heartburn, constipation. Treatment or management is always symptomatic relief. So doxylamine and pyridoxines are the best choice for most morning sickness, heartburn. Again, symptomatic relief and antacids are used: magnesium hydroxide, ammonium hydroxide. Caution should be taken while using ammonium hydroxide because overuse may lead to neurotoxicity. Then constipation, stool softeners can be used, but bulk laxatives are not absorbed. Try to avoid surfactants, stimulants, not recommended as first-line therapy. Avoid mineral oil because it impairs vitamin K absorption and can be a cause of hypoglycemia. For hemorrhoids, external medications are preferred. Avoid topical anesthetics and steroids. Headaches, acetaminophen is safe to use. Avoid aspirin, avoid NSAID and ergot alkaloid. Coagulation disorders. For the pregnant women, if they have coagulation disorders, warfarin is totally contraindicated. You cannot use warfarin. Only recommendation is low molecular weight heparin. And consider discontinuation of therapy 12 to 24 hours before cesarean or vaginal delivery if the doses are prophylactic doses. But if the doses are treatment doses, consider discontinuation of therapy 24 to 36 hours before the cesarean or vaginal delivery. We should continue anticoagulation for 6 weeks postpartum as well. And if woman is experiencing heparin-induced thrombocytopenia, consider fondaparinux. Now, yes, 29-year-old woman, height 65, weight 63, has a history of 2 deep vein thrombosis, but is otherwise healthy. She is seeking to become pregnant. She currently takes warfarin 3 mg orally daily. Which regime is the best recommendation for this patient? So we know warfarin we cannot take during pregnancy. So options are continue current warfarin to prevent clot. That's wrong. Continue warfarin therapy but increase the dose. It's again wrong. We are not using it any doses. Discontinue warfarin, start enoxaparin 40 mg sub-Q daily until pregnant and continue throughout the pregnancy. Option C is until now is the best. And then the option is discontinue warfarin, start heparin 5,000 units sub-Q every 8 hourly until 12 weeks pregnant and then reinitiate warfarin. So option C is the best answer because enoxaparin is low molecular weight heparin and is best to choose for the prevention of deep vein thrombosis. It's prophylactic dose and we can continue it throughout the pregnancy. Option D is again wrong because they are reinitiating warfarin after 12 weeks of pregnancy, which is wrong. Gestational diabetes mellitus. So there are two criteria to check gestational diabetes mellitus. Two-step approach, one-step approach. In two-step approach, 100 gram of oral glucose is tested. And then every 1 hour plasma glucose concentration is monitored. If the values of plasma glucose concentration is equal to or greater than the values 2 or more points according to the table, then we will consider that patient has gestational diabetes mellitus. In one-step approach, 75 gram of oral glucose is used to test plasma glucose and check the plasma glucose at 1 hour and 2 hours. And if at 1 or 2 point values are higher or equal to the stated values, consider patient has gestational diabetes mellitus. Treatment is insulin first line. Second line is sulfonylurea, but there is a belief that the sulfonylurea can cause hypoglycemia of fetus. So this second line, not first line. Metformin is still under investigation. Then pregnancy-induced hypertension. If hypertension occur after 20 weeks of gestation with previously normal blood pressure, we will consider it as gestational hypertension. If there is a pre-existing hypertension before the 20 weeks of gestation, it is not gestational hypertension, right? Then the condition preeclampsia, hypertension plus proteinuria, like 300 milligram or more every 24 hours, or any other severe feature of preeclampsia such as thrombocytopenia, impaired liver function, epigastric pain which is refractory to medication, and new development of renal insufficiency. Then eclampsia is tonic-clonic seizures. In chronic hypertension with superimposed eclampsia, it means new onset of proteinuria after 20 weeks of gestation. Like sudden 2 to 3-fold increase in proteinuria and sudden increase in blood pressure, increase ALT, AST, or thrombocytopenia. Prevention of this gestational hypertension or preeclampsia. So we can use aspirin as the best choice for prevention. And it is stated that there is a lower incidence of preeclampsia development in women who are administered 150 milligram of aspirin from 11 to 14 weeks of gestation until 36 weeks. Treatment is delivery if it is at full term. If not at term, bed rest, and monitor blood pressure. In severe preeclamptic condition, parenteral magnesium sulfate used to prevent seizures. Labetalol, methyl-dopa, nifedipine are first-line therapies to control hypertension. Then parenteral antihypertensives are hydralazine, labetalol. Medication to avoid for treating gestational hypertension, AT inhibitor, ARBs, and renin inhibitor and mineralocorticoid receptor antagonist. Preterm labor, middle complication. Term labor is 37 to 40 weeks. Ah, okay, okay. So preterm labor is uterine contraction with cervical changes before 37. Before week of 37. Non-pharmacological treatments are bed rest, hydration, and sedation. Then prophylaxis is with hydroxyprogesterone. IM every week from 16 to 36 weeks. Then we can consider tocolytic agents which inhibit uterine contraction. Beta agonist, terbutaline, magnesium sulfate, NSAIDs, indomethacin are oral or rectal, but they are not allowed to use beyond 72 hours. And calcium channel blockers are also used for inhibiting uterine contraction. They are nifedipine, verapamil. Induction of labor is needed in some cases where severe maternal infection or uterine bleeding or postpartum. Inducing agents are oxytocin, ergotolculoid, prostaglandins. Ergotolculoids are not mainly used for induction of labor for full-term pregnancy. It is used to terminate early pregnancies. Then there is a case, is the SE is 28-year-old woman who would like to get pregnant soon. Her medical history include hypertension or allergies, and her medication include lisinopril, nasal lung spray, and folic acid. Which option is best to treat her hypertension while she is pregnant or trying to conceive? So we know that ACE inhibitors are not recommended. So options are continue lisinopril, hydrochlorothiazide are wrong, discontinue lisinopril and other medication. No, we cannot discontinue. She needs treatment for hypertension. Discontinue lisinopril and start labetalol. This is the correct answer. And option D is continue lisinopril and anagenolol. So C in C and D, best option is we should start labetalol. An overview of contraception. So there are different methods for contraception. Barrier method, then combined oral contraceptive, including the progesterone on combined only contraceptive, then progesterone only contraceptive, then intrauterine devices, intrauterine system. In combined oral contraceptive, we have options of pills, transdermal patches, vaginal rings. Pills containing estrogen and progesterone combined and has progestin only also. Contraindication to use combined oral contraceptives are if patient is less than 21 days postpartum with no DVT risk. If patient is less than 42 days postpartum plus DVT risk. If there is a stroke, current breast cancer, migraine with greater than 35 years of age, CVD risk. Management of adverse effects of using combined oral contraceptives are breakthrough bleeding. This is important. Then nausea and acne. So how we are managing breakthrough bleeding? First, we will try to continue product for 3 months before considering switching to other product. This is called adherence. Then later, the next step, if bleeding is in early in cycle 1 to 10 days, we will choose new product which has high estrogenic activity. Second, if bleeding is appearing late in cycle, 10 to 28 days, choose product with high progesterone. Nausea will continue until 3 months and usually nausea subsides because of estrogenic activity. And acne, usually due to androgenic activity of progesterone. So we'll select the next product which has less androgenic activity or high estrogenic activity. Some serious side effects of combined oral contraceptives are abdominal pain, chest pain could be a signal of myocardial infarction, headache, stroke, blood clot. Eye problem can be a signal of optic neuritis, and severe leg pain could be signal of DVT. Case is 22-year-old woman started taking Mixed 4 months ago for contraception. She had breakthrough bleeding at the start of her active phase that lasts a few days before resolving. The physician wants to change to oral contraceptive. Which oral contraceptive on her formulary is best for the physician to prescribe? So she is taking Mixed for 4 months. 3 months already passed. So and she has still the side effect of breakthrough bleeding. So we can choose to another. We can shift to another product. Adherence is not the problem here. And the breakthrough bleeding is at the start of her active phase. So we will choose any product which has higher estrogenic activity than the Micrate itself, which she is using now. So options in formulary available are only Raclexin, which has high estrogenic property as intermediate as compared to Micrate. So we'll choose the option which show us change to Raclexin, that is option B. Okay, transdermal patches for contraception are not suitable for patients with BMI greater than 35 or who are weighing 90 kg, and vaginal rings should not be removed during intercourse. Then progesterone-only contraceptives are useful for those who cannot tolerate or who cannot take combined oral contraceptives, such people which have history of myocardial infarction, stroke, DVT, have high blood pressure, and smoker, and history of cholecystitis because of estrogen containing product, and migraine headache, retinopathy. Mechanism of action of progesterone only contraceptive pills is to suppress mid-cycle piece of LH and FSH and inhibit ovulation. It also thins uterus lining and thickens cervical mucus to prevent sperm movement. And they can be started on day 1, first day of period, and there will be no hormone-free days with progesterone. And should be taken at the same time every day, and missed dose is considered if there is a gap of more than 3 hours. So if there is a missed dose, backup method should be considered. Disadvantages: progesterone-related adverse effects, weight gain, acne, irregular menses. Adherence is the problem because of short window of missed dose. Depo-provera injection is IM and used every 11th to 13th week. Box warning for Depo-provera injection is it can cause loss of bone and reduce BMD of lumbar spine and femoral neck. And it is very effective method, almost completely reversible even after 4 years of use. And all women who are taking this Depo-provera injection should be taking sufficient calcium and exercise regularly because of this box warning of loss of bone. Every 11th is to 13th is the window for the next injection. And if 13 week is passed, then backup method is needed. It's considered as missed dose. Okay, so I have messaged that time is up and I have to wind up. And there are some topics. Some topics are left to discuss. And she's giving me option. Ayesha is giving me option to consider to continue it in other days. Okay, no problem. I can continue in other class. Just give me time. You really want to you really want me to finish now? Huh? So no problem. I have some only 2 or 3 topics remaining and not lot to discuss. If you give me half hour, I can continue now and finish it now. Otherwise, okay, fine. Tomorrow, fine, fine. I can come tomorrow to continue it. Up to you. What do you want me to do now? Please tell me. Hello, Ayesha or Dr. Anna? Okay, thank you. So we continue or only give me half hour. Okay? So we were discussing Depo-Provera injection. So if we are missed the window of 11 to 13 weeks, so backup method is needed, and it's considered as missed dose. And if we are considering switching method from Depo-Provera to another method, then we can start another method when next injection is due. But the drawback is in this Depo-Provera injection, it can delay the return to fertility for up to 18 months. So it should be used with caution in women with 35 years or older who express interest in future conception. Backup methods are condom plus spermicide, diaphragm, or no intercourse for 7 days. Intrauterine devices or intrauterine systems are used to prevent pregnancy for long terms, like 1 to 2 years of pregnancy protection. But they are contraindicated, especially copper IUD is contraindicated if woman has current or recent sexually transmitted infection, or woman at risk of sexually transmitted infection, whose uterus is less than 6 cm or greater than 9 cm, undiagnosed abnormal vaginal bleeding, active cervicitis or active pelvic infection, non-symptomatic actinomycosis, and recent endometritis. Patient case: 37-year-old woman says that she is getting married soon, weighs 95 kg, height 67 inch, and want to begin contraception for now. However, she would like to have children in a year or so. Her medical history includes hypertension for 2 years and GERD. She drinks 2 glasses of wine a week, smoke half pack of cigarette a day. Her medication includes hydrochlorothiazide, 25 milligram orally daily, amlodipine 5 milligram, benzo plus benzapril 20 milligram orally daily, omeprazole, and occasional ibuprofen. Which contraceptive product is best to recommend for LM? So she is 37-year-old and weighing 95 kg. Transdermal contraceptive patches are not recommended for patients weighing above 90 kg. She is hypertensive, so estrogen-containing products are not a choice. So oral tablet ethinyl estradiol is not a good choice. Oral tablet nortriptyline is can be considered. Then option D is Depo-Provera injection. Again, she is above 37-year-old and she want to have conception maybe after a year. We know that recovery to fertility can take up to 18 months. So Depo-Provera injection also is not a good choice for this. Only option C is left. So option C is the best for this case. Emergency contraceptive medicines examples are ESP, progestin only. Preferred for usually preferred and but not for BMI grade is equal to 26 or weight is equal to 75 kg. Ela ulipristal acetate not for BMI greater than 35 and backup method used for 7 days because it blocks progesterone receptors. Copper IUD it require office visit and misoprostol also require office visit. Infertility medicines. First line agent is clomiphene. It's also SERM and it acts by blocking estrogen receptor. And body perceives that there is hypoestrogenic state and increased release of GnRH with increased concentration of FSH and alert and stimulate ovulation. But there is a risk of multiple births with clomiphene. Metformin usually used in conjunction with clomid and it helps also in weight reduction, so there are better chances of ovulation. Then we have option of HMG, human menopausal gonadotropin. It is given from 2 to 3 till 7 to 10 days for 2 to 3 cycles and determine follicular development by estradiol level. It can cause flu-like symptoms. GnRH analogs, they are usually not used for infertility, but used for endometriosis mainly. It has caused increased risk of osteoporosis. Aromatase inhibitor, Femara, less risk of multiple birth, increased GnRH, and help to induce ovulation. Other options are progesterone, bromocriptine, sildenafil, guanfacine, help in cervical mucus to aid conception. Then aspirin can be used before fertility procedure for uterine blood flow and decreased risk of ovarian hyperstimulation syndrome. And last topic is sexually transmitted infection, including paralytic inflammatory disease and gynecological infections. So infections, first is syphilis. Symptoms is development of changes, non-pain ulcers, gingivitis. Primary syphilis, treatment is benzathine penicillin G 2.4 million unit IM in a single dose. And if there is a penicillin allergy, doxycycline orally twice daily or tetracycline 4 times daily for 2 weeks. Secondary syphilis, after 4 to 8 weeks of exposure, benzathine penicillin G treatment of choice IM as a single dose. If there is a penicillin allergy, doxycycline twice daily or tetracycline 4 times daily for 28 days. So duration is different for secondary syphilis, 28 days, for primary syphilis, 2 weeks only. Late latent syphilis, treatment again, benzathine penicillin G 2.4 million units IM every week, now for 3 weeks. If there is a penicillin allergy, doxycycline or tetracycline for 4 weeks. Then neurosyphilis. Here treatment is crystalline penicillin G 3 to 4 million units IV only every 4 hours for continuous infusion for 18 to 24 million units per day for 10 to 14 days. If there is a penicillin allergy, ceftriaxone IM should be considered for 10 to 14 days, or best option is that patient should be desensitized and give penicillin. Second, herpes simplex virus. Important point to remember for herpes virus that after the primary infection, virus is still latent in the sacral dorsal root ganglia, and treatment can partly control the symptoms but does not affect the risk frequency, and severity of reoccurrence after it is discontinued. Treatment options are acyclovir, famciclovir, valaciclovir. Daily suppressive treatment for 1 year in patients is recommended with 6 or more episodes per year. Daily suppressive therapy is either twice daily or once daily regimen. And some cases which are severe should be hospitalized and treatment should be by IV acyclovir every 8 hours for 2 to 7 days and followed by oral antiviral therapy for at least 10 days of total therapy. Herpes encephalitis symptoms are headache, fever, speech disorders, focal seizure, and can be diagnosed by CSF analysis. Therapy is IV acyclovir for 21 days. Clinical case. DH is a 21-year-old woman who presents to clinic with genital itching and vesicles on her vulva. She is sexually active with one partner who has history of herpes. Her partner does not always use condom when have sex. She is initiated on acyclovir for this initial adversary infection. Which statement is best to mention to DH regarding the treatment of her herpes infection? The option A is treatment of the initial infection will decrease the risk of recurrent herpes infection. So we know that risk, severity, and reoccurrence is not affected by initial treatment. Only treatment can shorten the symptoms of infectivity. And virus will remain latent in the dorsal root area. So option A, C, and D are wrong. Only option B is correct, that treatment will shorten the duration of symptoms and infectivity of initial infection. Then case. BH returns to the clinic 10 months after her initial herpes infection. She is troubled by all the recurrences she is having 7 to date. So she has now in 10 months period 7 recurrence. Right? And we know that if in 1 year there is 6 reoccurrences, daily suppressive therapy is recommended for 1 year. So question here is, which therapy is best to recommend? And we know daily suppressive therapy is with once daily regime or twice daily regime. Option A and B are wrong because they are giving duration only for 5 and 10 days. We need daily suppressive therapy for 1 year. C and D showing suppressive therapy but with famciclovir giving option of 3 times daily. Suppressive therapy is needing only for daily or twice daily. So option D is correct in this case. The next infection topic is chlamydial infection, and it can lead to pelvic inflammatory disease and lead to ectopic pregnancy and infertility. Option is azithromycin. Treatment option 1 gram every single dose or doxycycline 100 mg twice daily for 7 days. Then gonococcal infection. Penile discharge and dysuria common in men, but women are often asymptomatic, which again can lead to pelvic inflammatory disease. So it is really needed to diagnose correctly. Options for treatment are ceftriaxone 250 mg IM plus treatment that covers chlamydia, if chlamydia is not ruled out. So gonococcal infection treatment is always ceftriaxone plus azithromycin. But if chlamydia is ruled out, so only ceftriaxone IM 250 mg. Next is pelvic inflammatory disease. Symptoms are lower abdominal tenderness, elevated erythrocyte sedimentation rate, elevated C-reactive protein. Sequence is like abscesses in pelvic or fallopian tube, tubal occlusion, fibrosis, and infertility. So PID leads to infertility and ectopic pregnancies. Treatment options are cefotetin 2 gram to 12 hours, cefoxitin 2 gram to 6 hours plus doxycycline 100 mg IV or PO to 12 hours. Total duration is 14 days. There is another regime, clindamycin to 8 hours plus gentamicin or gentamicin IV or IM as loading dose, then 1.5 milligram per kg Q8 hour or once daily therapy with 3 to 5 milligram per kg dosing. Alternative regimes are ampicillin sulbactam 3 gram IV to 6 hours plus doxycycline IV or PO to 12 hours. IM treatment ceftriaxone 250 milligram plus doxycycline 100 milligram to 12 hours with or without metronidazole. Last is prostatitis. Here we should be careful with the primary organism which cause prostatitis. This is C. trachomatis, Neisseria gonorrhea, and Escherichia coli. Symptoms are urethritis, asymptomatic, primarily gram-negative organism, Clostridium trachomatis, and Neisseria gonorrhea are E. coli. So acute treatment is of 14 to 28 days and depends on organism. Ceftriaxone IM for gonorrhea and fluoroquinolones like ciprofloxacin twice daily, levofloxacin once daily, or ofloxacin twice daily. Cotrimoxazole twice daily or trimethoprim 200 milligram twice daily. If chronic bacterial prostatitis symptoms are greater than for 6 months, therapy duration is increased. Can be longer up to 6 weeks, and in some refractory cases, it can be prolonged up to 12 weeks. Again, it depends on the organism which treatment regime should be considered. So fluoroquinolones are the options: ciprofloxacin, ofloxacin, levofloxacin, then minocycline, 100 milligram twice daily, doxycycline, trimethoprim, 200 milligram twice daily, or cotrimoxazole, double strength twice daily. So this was the last slide for lecture. Okay, Ayesha, finally I finished it. Sorry, I take a long time.
It's okay, ma'am. Thank you so much for being part of a Nobel cause. And that was all for today. And dear participants, if you have any query, you are welcome to ask. You can unmute your mic or you can put your question in chat box. If no, then we can close the class and see you in the next class. Till then, Allah Hafiz.
Okay, no questions? You can close?
I guess yes. Thank you, ma'am.
Okay, thank you so much. And if there is any question, you can ask me later. There is one. I think there is one. No questions? Okay. Okay, thank you.